Okay, good afternoon, everyone. I'm Linda Cam. I'm the pharmacist at the VA hospital across the street. And I chose to do this topic because I had some requests this month to talk about some aminoglycoside dosing. For those of you who've been doing this for a while, this may be a little more elementary, but I kind of wanted to go over some basics, and then at the end I wanted to go over a few cases of patients that we actually had, and then kind of open it up for discussion as to how you would dose those patients. So just in general, aminoglycoside pharmacodynamics, we know that aminoglycosides are bactericidal, so we use them all the time. They're actually excellent drugs. They've been around since the 40s, and they've held up in their susceptibilities. They work by binding to the 30S and 50S ribosomal subunit, and that's how they work in their bactericidal activity. Besides having gram-negative activity, we always think of aminoglycosides being a gram-negative agent. They actually have pretty good gram-positive activity. And for some infections, we do use aminoglycosides for gram-positive infections. They are concentration dependent, which means the higher amount of drug or the higher concentration you give a patient, the more bactericidal activity you will get from that medication. And they have what's called a post-antibiotic effect, which means that as a drug is eliminated in your system, even below the MIC, there's still bactericidal activity present. And I'm going to go into some demonstration of why these characteristics actually help us in some of our dosing mechanisms. However, one of its major limitations, and those of us who've used aminoglycosides know, nephrotoxicity is a major limiting factor with aminoglycosides. They're usually associated with patients who have excessive trough concentrations. So if you have trough concentrations that are too high, obviously they can cause the nephrotoxicity. And if you expose the patient to the aminoglycoside for an extended period of time, you will enhance the risk of nephrotoxicity. One thing I didn't add on here, the other thing is the ototoxicity, which is mainly associated with high peak levels. Unfortunately, the literature does not have a whole lot of data on ototoxicity. We know it is a limiting factor, but it's not measured a lot. I think part of the reason is we don't really do baseline audiologic exams in a lot of our patients. We don't really assess for their baseline hearing before we put patients on aminoglycoside. So I think it's underreported because we don't really look for it. And then lastly, aminoglycosides have what we call synergistic effect. So it's more of a 1 + 1 = 3 type of phenomenon. Instead of an added effect, you get a synergistic effect. And we use those aminoglycosides oftentimes with beta-lactams, extended spectrum penicillins, and then vancomycin as well. There are different methods to dosing of aminoglycosides. The traditional way of dosing, we call this traditional or small dose, short interval dosing. This is the usual Q8-hour, Q12-hour, Q24-hour dosing. With the once-a-day way of dosing, you will see patients on Q-day dosing, sometimes extended to Q48 or even Q72-hour dosing. This is also known as the large dose or extended interval dosing, and there's various nomograms in the literature that supports the use of once daily dosing by using these nomograms, and we're going to go over those in a minute. Hartford, which was the original nomogram published out of Connecticut, used a lot of this in the 90s. So there's a lot of literature from the Hartford Nomogram. Barnes-Jewish have published a kind of a modified nomogram. The Sanford guide offers some recommendations as to how to dose, and then the University of Rochester also has kind of a modified Hartford Nomogram as well. And depending on what institution you're at, they may use any of those versions. So let's kind of go into depth about traditional dosing. This is your traditional small dose, short interval, where you measure your peaks and trough. We know that aminoglycosides offer synergy with the beta-lactams, extended spectrum penicillins, and vancomycin, which I touched on. And essentially what's happening is you're giving a patient a drug, and after 3 or 4 half-lives, a patient reaches steady state. And at that point, you would measure the peak up here and the trough to make sure you are not within toxic levels and you're obtaining high enough peak to treat the type of infection that your patient has. So in the Sanford Guide 2009, the recommendation for traditional dosing aminoglycosides is a 2 milligram load, if we're talking about gentamicin or tobramycin, followed by 1.7 milligram per kilo dose, dosed according to their creatinine clearance. So if you have a patient that has a creatinine clearance between 50 or 90, they do recommend Q8-hour dosing, and so forth. For amikacin, the recommendation is a 7.5 milligram per kilo dose, and these are the intervals that are recommended for amikacin in the Sanford Guide. Keep in mind when you're using traditional dosing, depending on the type of infection you have, because aminoglycosides do not penetrate some areas very readily, like the lungs, it's recommended for certain types of infection that you shoot for a higher peak. So, for example, with pulmonary infections, the desired peak should be closer to 7 or 10, and in some institutions I've seen them push it all the way up to the 10. Whereas if you're using aminoglycosides in synergy with the beta-lactam, for example, desired peak can be as low as 3 to 5. And in urinary tract infections, because aminoglycosides are almost 100% eliminated in the urinary tract, peaks of 4 or 5 are adequate for those types of infections. And down here, when you're treating pseudomonal infections, the recommendation is 8 times the MIC. So if you have an organism that MIC is 1, for example, you would probably want a peak of at least 8. So a toxic peak would be kind of in your 12 to 14 range. It increases the risk of auditory or vestibular ototoxicity, and it's usually a more permanent damage. And the patients lose, they can't really hear the high frequency tones when this happens. And loss of balance is another problem that they can present with. In terms of troughs, we want to keep the patients at the desired trough. It's usually less than 2, 1 to 5 or 2. Aminoglycosides offer a post-antibiotic effect, so lower trough does not affect the efficacy. So I think it's better to shoot lower than it is to shoot higher for troughs, because you don't want to push the patient over the edge, if you will. And you don't really lose toxicity or efficacy when you have a lower trough. Low trough decreases the risk of renal toxicity. Anything higher than 2 to 3 would be in the toxic range. It actually increases the risk of nephrotoxicity. Fortunately, it's usually reversible. So if you stop the offending agent, patients' renal function returns. Keep the trough in the range, and risk of renal toxicity increase when given with other renal toxic agents. So keep that in mind. If you're using other renal toxic agents, an example would be things as simple as Lasix. If they're dehydrated, you're going to increase their renal toxicity. If you have a patient on a beta-lactam, which can induce acute interstitial nephritis, you can actually kind of push the patient into renal toxicity if you have them on gentamicin as well. Now let's change gears and talk about extended interval, or also known as once daily dosing. Other terms that are used synonymously: extended interval dosing, pulse dosing you might hear, and then large dose extended interval dosing. Microbiologically, it's comparable, and cure rates are comparable when patients are put on once daily dosing versus the traditional dosing in the majority of infections. It does cause reduced nephrotoxicity. There's been head-to-head trials comparing patients on once daily dosing versus traditional dosing, and the patients on once daily does have a little lower risk of nephrotoxicity. However, there are limited studies looking at ototoxicity, and technically you would think that they would have an increased ototoxicity because you are giving them such a high dose, and the peaks are what's associated or linked to the ototoxicity. So theoretically you would think they would have increased ototoxicity, but again, I don't think it's a very well studied, or we don't really look for ototoxicity, so it may be underestimated because of that. Prolonged interval may allow diffusion of the aminoglycoside outside of the relevant tissues. So the theory is, by giving these large doses over an extended period of time, you're sparing the renal capsule, and therefore allowing the renal parenchyma to be drug-free for an extended period of time. There are various nomograms that adjust the dose based on single post-dose level. So the rationale behind once daily dosing is because of this concentration dependent killing, which we touched on, and you want a higher peak to MIC ratio because it gives you the higher kill rate. And I'm going to give you an example of a peak to MIC ratio with a diagram in a minute, but basically what you're doing is you're increasing your peak to MIC ratio from, say, a 10 from once daily dosing to about a 3 in traditional dosing. In the next slide I'm going to show you an example of that. Post-antibiotic effect, the theory is anywhere between 2 to 6 hours is how long you have a post-antibiotic effect. So if you're below the MIC for 2 to 6 hours, potentially you're still getting the bactericidal activity of your aminoglycoside. And basically this is what's happening. However, some of the criticisms with once daily dosing is that you are drug-free for an extended period of time, anywhere between 3 to 5 hours, sometimes even longer, depending on how you're dosing. And no one really knows what is the threshold for drug-free interval. I mean, do you get more infections if you're drug-free for 8 hours, or do you get less infections if you're drug-free for a shorter period of time? So if you have a patient who's septic and you're really cautious and you don't really want them to be drug-free, I don't think the studies have really proven what the maximal drug-free interval is. So you may hear some of the criticisms about that. So this is the example. In traditional dosing, say your MIC is 2, the CP max that you're getting with traditional dosing, say you want a peak of 6 and your trough drops down below 2. So over 8-hour interval, you would give them another dose, and your CP max to MIC ratio is 3 in this case. In the same case, MIC of 2, but you're pushing your CP max, your MIC dropping down, you are actually getting some post-antibiotic effect here because you're below the MIC, and then you're actually drug-free here, this drug-free interval. So you're pushing your CP max to MIC ratio up to 10 by using this phenomenon. So there are some limitations of once daily dosing. Some say it's a fixed dose approach. Not one dose fits all the patients. So some people would be reluctant to use it. It's not adjusted for the infection type. Whereas, with the traditional dosing, depending on how well the drug penetrates into that area, we may adjust the dose and shoot for higher peaks. With once daily, there's really no dosage adjustment for the infection type. It's not individualized based on a patient's kinetic properties. So, if you have a patient who's obese versus if you have a very lean patient, how do you adjust for that? So there are some limitations. Patients who have high clearances, i.e. your young adults, your CF patients, extended burn patients, those patients haven't been really studied. If they've got greater than 20% of their body surface areas with burns, traditionally we would have to dose these patients a little more aggressive, but there's really no recommendations as to what percent increase you would provide for these patients. Other populations that have not well been studied include patients with ascites and patients with dialysis. And I touched on the excessive drug-free interval. No one really knows what the ideal, or if you go above a certain time, if it's detrimental for the patients. And in the pediatric population, it hasn't been well studied, and also pregnancy. In situations where you would want to avoid once daily dosing, in patients with severe renal disease, creatinine clearance less than 30, when used for synergy in certain gram-positive infections, and that would include, example, will be enterococcal endocarditis, and that's because the post-antibiotic effect with enterococcal or streptococcal disease has not been substantiated, and actually has a very reduced post-antibiotic effect when it was studied with this organism. History or signs of hearing loss or vestibular dysfunction would be another example of when you would maybe want to avoid using once daily dosing. And essentially what you do is you give the patient a dose based on their milligram per kilogram, and then you obtain a mid-interval drug level between 6 to 12 hours later after the initial dose. And you don't have to wait for steady state, because what happens, these patients really never get to steady state. You're only giving them one dose and letting them eliminate over a period of time. So you don't have to wait the 3 or 4 half-lives. You can do it with that first dose that you give them. Then evaluate the interval based on the dosage of the nomograms. If the level that you obtain at the 6 to 12 hour level is undetectable, or the patient is responding, you might want to consider changing the patient to traditional dosing. This is out of the Sanford guide for the once daily recommendations, and they kind of have they don't really use the Hartford, they don't really use the Barnes-Jewish nomogram, they kind of have a melded approach to this. And so basically what they're doing is, for patients with normal creatinine clearance, so patients with a normal creatinine clearance of 80, they're recommending about a 5.1 or 5 milligram per kilo, and you give it every 24 hours. They recommend going up to 7 if patient is critically ill, and then adjusting based on their creatinine clearance. So reducing the milligram per kilo dose if their creatinine clearance is less. For amikacin, the recommended is 15 milligrams per kilo, Q24 hours, and then adjusting the milligram per kilo if that's what your patient falls into. In the Sanford guide, they actually give some recommendations on peak and trough monitoring and once daily dosing. I would say the majority of the practices do not do this, because you would need to get a peak at about 1 hour after the dose, and you're going to get a call with a critical value, because you're going to get a peak of like 20. And so I think the majority of the sites do not do a peak at the first hour, they just do the random. And then also Sanford guide suggests getting a trough at about less than, getting a trough of less than 1 mic per ml. Again, I don't think most of the sites do this, but this is in the Sanford guide. Monitoring of these patients. Obviously, you need a baseline serum creatinine. You should at least check them weekly while they're on therapy. Get a trough level during the last hour of the dosing interval if you're doing troughs, or get a random if you're doing randoms. And then alternatively get a random. So this is the Hartford Nomogram. And what they recommend is the 7 milligrams per kilo. So it's a straight, everybody gets 7 milligrams per kilo, straight dosing. And at the same, anywhere between a 6 to 12 hour interval after the dose. So say you give it at 1 o'clock, at 6 o'clock or 7 o'clock, or anywhere in between here. Say you get it at 10 o'clock. If the level is, say, 4, then the patient stays on 7 milligrams per kilo, Q24 hours. But if the interval at 10 hours is, say, up here around 6.5 or 7, then they would keep this patient on the 7 milligram per kilo, but you need to extend the interval to Q36 hours. And the same thing with the 10-hour interval at the Q48. So if at the 10-hour interval the level's 9, then Hartford Nomogram recommends keeping them on the 7 but extending your interval to Q48 hours. This is the nomogram for amikacin, if you're using amikacin. Similar phenomenon, using the 15 milligram per kilo, and at the 10-hour interval, if they're like in this range, then you keep them on Q24, and same thing, keeping them on the same milligram per kilo and adjusting your interval. This is what University of Rochester uses, and I know some of the hospitals up in the Northeast kind of use this. They use a 5 milligram per kilo instead of the 7. So you're going to get some variability depending on where you go. And they kind of do the same thing with the nomogram, but they use a reduced dose with that. And their nomogram is a little bit different. Barnes-Jewish, again, uses 5 milligram per kilo. It doesn't use the 7. And they adjust it based on the interval with the dosing. So at the 10-hour interval, if your level is 3.6, then they would keep it Q24. 5.9 goes to Q36, and 10 would go to Q48. I think from personal experience, the 7 does seem to be a little high. I used to do a lot of the 7s, and a lot of times I felt like I was overshooting. So with the 5, it seems like it's more of in the ballpark with what I've been doing. Amikacin, same thing. They do use the 15 though, so it's the same. with the Hartford and the Barnes-Jewish, and the same sort of phenomenon with the amikacin. This was a study that was published in 2002, and they evaluated the various methods of once daily dosing, looking at Hartford, Barnes-Jewish, University of Rochester, and then also they threw in there the Sanford guide and what the different ways of doing it. So as you can see, the major difference is the milligram per kilo dose, and then the intervals amongst the three are basically the same. And what they found was when they looked at the 4 nomograms, their N was about 90 patients looking at those 4. There were many inaccuracies in dosing amongst the various regimens. There's variability in patient pharmacokinetics across the board with these regimens, so they really couldn't make any consistent conclusions about how these 4 compared in terms of which one was more effective. They did recommend that individualized dosing with therapeutic drug monitoring should be used. So, not everyone should get 7 and not everyone should get 5, for example. And maybe there should be some variability between what patients you're treating. Toxicity-wise, we know that gentamicin and amikacin accumulate extensively in the kidneys, and tobramycin is a little less renal toxic. Clinical trials are not consistent, however, but clinically, I think the consensus is tobramycin is a little less toxic than gentamicin and amikacin. So other ODA methods, Mayo Clinic uses another one. Everybody stays on Q 24 hours, and they adjust it. They adjust based on the milligram per kilo. So that's how Mayo Clinic does it. They start with the 5 for creatinine clearances of 80 or above, reduce it down to 4, but everybody stays on Q 24-hour dosing. I've not really used this one myself. I've mainly used the Barnes-Jewish and the Hartford Nomograms. So depending on where you go, you may see some variability as what once daily really is. And it's kind of a misnomer, or in some cases, because patients aren't always on once daily dosing. So individualizing the single daily dosing is probably the way to go. Adjusting for creatinine clearances, maybe using a higher or lower milligram per kilo if your patients kind of fall into that categories. There's even recommendations for the type of infections now. If it's a mild or moderate infection, they recommend maybe getting the higher peaks, so maybe you want to use the higher milligram per kilo versus if it's a lower milligram per kilo, and if it's a more severe infection, trying to get higher Cmaxes and therefore using the higher milligram per kilo. So just to kind of go over a couple of cases. This is a 60-year-old male, 67 inches, 80 kilos, persistent MRSA bacteremia, pneumonia maybe is a source versus ruling out endocarditis. So right now we have him in Periclam, vancomycin, meropenem, and gentamicin. Again, gentamicin here could be for gram-positive, right? White count's 9.9, creatinine seems to be okay, BUN seems to be okay. So our target peak and trough in this guy would probably be what? We're using it in synergy probably for this MRSA bacteremia. I guess you could argue if you're using it for pneumonia, you may want to shoot for a higher peak or trough. But if we're our primary diagnosis would be this endocarditis with this persistent MRSA bacteremia, what would be the target peak and trough? Anybody? For synergy, you don't need that really high peak trough, right? So probably just 3 to 5. You don't need to shoot for 10 or and then trough, remember we want to keep it less than. And then how would you dose this guy? Would you do once daily? Would you do traditional dosing? Remember, right. So what is it? 1 milligram per kilo IVQ8, right? So he would probably go on 80 Q8, right? Okay, So case 2, this is a 78-year-old, 100 kilograms. He's diagnosed with MDR Pseudomonas bacteremia with a pneumonia, and he's got Candida tropicalis fungemia on top of that. So you have him on amikacin, cefepime, and micafungin. And his white count looks like he's started to respond a little bit. BU and serum creatinine looks good. Amikacin dosing, would you do once daily or traditional dosing in this guy? Once daily. You could do once daily. What would be your target peak and trough, if any? In this case, probably not, right? Because if you're going to do once daily, you're going to use a monogram. The key here is look at his weight. He's 100 kilograms, so he's a lot. He's only like, I think ideal. He was only like 70 kilos ideal. So you got to be careful with that, because if you're dosing aminoglycosides, you probably want to use their ideal in this situation and not their actual weight. So you want to use either their ideal or their dosing weight in this case. So the actual dose, we're going to do once daily, and we're going to use their dosing weight. So we're going to use 15 milligrams per kilo times whatever their dosing weight calculated to be, and I think it was like 70. So we put them on amikacin 1100 Q 24 hours. And then when do you get a level? You want to get a level at 6 to 12 hours. Usually I just write for 10. It's just easy for people to remember. And you can do it with that first dose. You don't need to wait for them to reach steady state. And then the actual level came back 10 hours later, and it's 1 point. The first dose is 12.7. So your 10 hours, 12.7 is right around there. If I can line that up right. It's like right on above that line. So if you use the Hartford Nomogram, which that is, would you change dose? No. Yeah, so you could probably extend him to Q36 and keep him on the same dose. Yeah, and then another 10 hours after that dose. Yep. Back up a little bit, right? Okay, third case. I think this is my last case. 61-year-old, 63 inches, 93 kilos, MDR Klebsiella UTI. So he's on tobramycin 5 milligrams per kilo daily, and then a level drawn at 19 hours, which is 13 hours later, is 6.1. So what do you do? So based on, if you're using the Barnes-Jewish, which doses at 5, so 13 hours later, it's 6.1. So he's like up in this range, right? So what would you do? Well, remember, with these, there's no infection type dosing. These are kind of straightforward, cookie cutter type. Everyone gets the same milligram per kilo, unless you're doing kind of a melded approach, which some people have proposed. Being more aggressive if you're treating a very severe infection, and being less aggressive if you're treating something like that. But if you're using this, straight out of the book, it's 5 milligrams per kilo, and that's it. It doesn't matter what your type of infection you're treating. So those are some of the criticisms about this approach. So what would you do? The creatinine is 1.3. So you can stop ODA and go back to traditional dosing. You can change it to Q36 to Q48 hours, because if you think he's kind of in this range, and then with that creatinine going up, or you can go back to the traditional dosing.